And by the way, it's live on YouTube, and the link I already sent. So anybody can not have a problem, they just can go to YouTube and listen.
Oh, that's great.
Yeah, we have 1 more minute, so if you guys be ready, huh?
Yeah. Ready.
Yeah, Dr. Mustafa, he joined now.
I think we can start, no problem.
Assalamu alaikum wa rahmatullahi wa barakatuh. How are you, Dr. How are you, Dr. Anwar?
Yes, Dr. Mustafa.
Hi, Dr. Mustafa. How are you?
Yeah.
And Dr. Muhammad, how are you? Dr. Yahya, how are you?
Hello, Mustafa.
Hi, Dr. Mustafa, how are you?
Good. Hi, Malad, how are you? I'm fine, alhamdulillah. Thank you, Doctor.
I think I can start, Dr. Yahya.
Yes, sir. Go ahead.
Hi, everyone. Thank you very much for joining our call today. Good evening and good afternoon to everyone. Actually, I would like to thank Dr. Anwar and Dr. Yahya for making this activity happen. Thank you very much for all the knowledge that you are giving to our colleagues. Dr. Anwar Khan actually is the host today. He's a consultant neonatologist and the head of the NICU department in Dubai Hospital. And I will leave the floor to Dr. Anwar. Please go ahead.
Hi, good morning, good evening, everybody. Actually, it's a great pleasure actually to arrange this particular meeting. We were actually looking forward for someone who is an expert and using the machine regularly, who can talk about this NIRS or NIRS, because monitoring newborn babies, especially preterm babies, is developing every day, and we are looking forward to how to monitor. We have to get a new outlook to monitor premature babies, to know their oxygenation, tissue oxygenation in particular, and to answer many questions in their prognosis and outcome. Dr. Yahya is very well known to me. We are actually knowing from last couple of years, though he's pretty new to UAE, maybe for 1 year at least, and very well known in his talks and training programs and speeches. Very, he's always a pioneer to invite people and to talk about different scientific topics. And we really enjoyed his talk. And I'm sure today also you will all will like it very much. And many questions which we have for NIRS would be answered today, because mostly if you are going to use a machine, you have to know all the aspects of the machine, and also how to interpret the readings and how to apply on your clinical scenario. I'm sure Dr. Yahya has already planned it, and he has divided this talk into three sections. The first one is the basic, the mechanism and the basics, and then he will talk about the application, and then he will discuss the clinical scenario. I'm sure that you'll like it. Dr. Yahya, the stage is open for you, and please go ahead. Thank you.
Dr. Yahya, you are still on mute. Can you please unmute yourself?
Do you hear me now?
Yes.
Yeah.
Yeah,
Please.
thank you, Mr. Dr. Khan, for the introduction. Thank you for Malad and Mr. Sadiq, Dr. Mustafa for the organization of the session. I'm always delighted to be here and share the knowledge and improve. And with more, I do this presentation because I'm fascinated with NIRS and other type of beyond the usual monitoring. And then with more talks, I get more knowledge, more experience, and I understand different aspects of this devices and others. So as Dr. Khan was saying that I divided the talk to 3 sessions. I hope I can finish them all. And the first one will be about the basics and the principles, and the second one about the clinical application. And hopefully at the end, I can discuss some cases from the usual live scenarios, and hopefully I can answer some questions. Because the time limited, so I will pass some not very important slide like normal values. I can provide it as a PDF for people to review, but I will concentrate on understandings of the technology. So let me share my screen with you. And do you guys see me?
Yeah.
Okay, great. So as I said, we'll start with the basics of near-infrared spectroscopy. So to disclose this, of course, sponsored by INVOS. However, I am not here to advertise for any companies. There are more than 5 companies in the market providing the near-infrared device, and each one of them has the benefits and drawbacks, and you guys, according to what you listen today and according to your knowledge, you can decide which company. And INVOS, I'm sure they have very good machine, they can advertise for themselves. So the purpose of the first session is to give you some definitions, and then tell you why, and give you some normal values and how we present the data and what's available designs, and give you some tips. I will pass the future projection because not this time. So for a human being, the outside looks like this. However, there are other ways to look at nature and a different aspect of this life. And so we have to look to the life beyond the usual, outside the box, using anything more than the visible. So how we can do that? We can do that with infrared camera. It will measure the temperature and give us some information. We can use high-speed visible light camera. Usually we see 25 frames per second. So any speed more than that, we don't see it. So for example, we don't see a bullet moving because it's moving at 300 frames per second. So if we have a camera that can measure or can record 300 frames per second, then spread it out and move it slow, then you can see the bullet moving. So that's another aspect that you can see through high-speed visible camera. You can use CGI, computer graphic imagery, and that's used usually in Hollywood. You can use Kinect, which measure the angles, or you can use the RIT, which is measure the movement of the chest during respiration, or you can use the TIP, which measure the electric changes during breathing. You can use leap motion, which is measure the 3D dimension, same with the PlayStation. And you can use the NIRS, or near-infrared spectroscopy. So today our topic is about NIRS. However, we have other tools such as ultrasound, CT scan, MRI, that's already in the practice. So once we use this machine, we can see in a real time. We can see it on the monitor, as a numbers or as a graph. And we can see it in another way. We can take the data, present it in a way, and then show it to us again as histogram or as a frequency table. Now, what is infrared? Now, we know that the visible light wavelength is somewhere between 200 to 600 nanometer. The last color that we see is the red color, which is around somewhere between 550 to 600. After that 600, we don't see. But before the infrared, which is 800 nanometer. So in that area, what we call it infrared, because the length becomes slower and slower because the frequency is increasing. So it's below the red, or it's infrared. So where is this near infrared come from? It's an area between the visible light and the infrared. And as you know, the infrared is of 3 types: the mid, the short, and the long infrared. The near infrared is somewhere between the short infrared and the visible light, or the end of the visible light, which is the red color. So we know what is infrared. What is spectroscopy? Spectroscopy is a study of interaction between a matter and electromagnetic radiation. How that works? For example, if we take the visible light. So the visible light can be dispersed according to its wavelength by prism. So the interaction of the electromagnetic field with the matter give us something. So if we combine both near infrared with spectroscopy, we get near infrared spectroscopy. So what does that mean? We use the wavelength of 690 to 880 nanometer, or in another word, 0.69 to 0.88 micrometer, to measure a physical output from the body as electromagnetic field when it interacts with the matter. And this gives us a continuous direct measure of local tissue oxygenation. Why? Because the oxyhemoglobin wavelength is around 600. And therefore, it can give us local tissue oxygenation or oxygenation in general. The pulse oximetry gives us also the oxygenation. However, the near infrared give us the oxygenation from different perspective. So what is near infrared spectroscopy? To make it more clear, let us use local tissue saturation as an example, or let's use the brain. So the physical output from the brain due to presence of oxyhemoglobin can be measured by infrared and can be seen by spectroscopy, or both called NIRS, near infrared spectroscopy. The local tissue oxygenation, or what we call it another way, regional tissue oxygenation, RSO2, is expressed as a percentage like a pulse oximetry from 0 to 100%. And again, it represents the hemoglobin oxygen saturation in all sections of the blood vessels. However, it's more venous weighted. We have the pulse oximetry that measures the oxyhemoglobin, but it's more arterially weighted. So it measures more in the arteries, while the near infrared measures the hemoglobin oxygen saturation more to the venous side. As I said, the pulse oximetry used the same wavelength, but it used a different technology to measure the oxyhemoglobin. It's again ranged between 0 and 100, and the normal more 94, but it's more arterial weighted. So local tissue oxygenation or venous weighted is by NIRS, while general systemic oxygenation measured by pulse oximetry. Now, what is the tissue oxygenation index? It's also called regional oxygen saturation, RS2. And it's again measured, as I said, it's measured by NIRS, near infrared spectroscopy, or a combination of near infrared and spectroscopy. And it measures the whole vasculature, the arterial vein. But because it's local and because there is more vein there, it's more venous weighted. We've said the pulse oximetry saturation normally more than 94 in a term baby. However, the normal range for the regional RS2 or TOI is somewhere between 55 to 85, a little bit wide range. We'll talk about that later on. Because they have a pulse oximetry that measure arteries or more arterial weighted, and we have NIRS that measure the venous, which is more venous weighted, then the difference between the pulse oximetry measurement and the NIRS measurement give us the oxygen consumption. And usually the oxygen consumption ranges somewhere between 15 to 33%. So normal pulse oximetry 94, normal TO or RSOT is 55 to 85, and normal oxygen consumption between 15 to 33%. So we said it's a regional oxygen saturation, and therefore we have different regions. But we define these regions into two main regions, the cerebral and the somatic. And the reason the somatic almost the same, because the factors that affect the saturation, localization, are the same. So the factors that affect the brain or cerebral saturation, local tissue saturation, is affected by blood flow, by perfusion, and the ability of the brain to extract the oxygen. While the somatic is only affected by flow and oxygen extraction. It does not affected by perfusion. Both somatic and cerebrum can be measured by NIRS, or the local tissue oxygenation of those two organs. There are other factors called fractional cerebral tissue oxygenation fraction, and it represents the same of tissue oxygenation or oxygen consumption divided by saturation, by systemic saturation. It's called FTOE, not much used. So again, it's oxygen consumption, which is different between blood, arterial, or systemic saturation, and regional saturation, divided by systemic saturation. And the FTOE represent the tissue perfusion. And therefore, it's very important in the brain. It's less important than in the somatic. Now, we have something called autoregulation. Autoregulation is important to keep the tissue oxygenation to the brain and derive it from other vital organs during stress. And to find the cerebral or somatic autoregulation, you can subtract the percentage of oxygen saturation, systemic or arterial, from the mean arterial blood pressure. Or when we say mean arterial pressure, we mean invasive blood pressure. It's usually stable in cerebral, which means that the autoregulation is not affecting the brain, while it's very variable in somatic. So once it's a variability is there, you know that the autoregulation is not working. Once the variability goes, you know that the body starts to be exhausted and cannot use the autoregulation anymore to keep the saturation of the brain. Now, why NIRS? Because it is the only tool that can adequately assess the perfusion. Because we know the perfusion is a very clinically challenging to measure. The oxygen saturation measured by arterial or by pulse oximetry, and lactate level, and urine output, heart rate changes, blood pressure monitoring, capillary refill, and other tools are blunted. What does that mean? It happens after the damage to the tissue, or after the tissue are being derived from the oxygen or oxyhemoglobin. And therefore, they are latent indicator of local tissue perfusion. We can also use echo assessment. However, the echo is not continuous. Therefore, NIRS can provide continuous monitoring in real time of local tissue oxygenation. And it gives us a real-time continuous measurement of the oxygenation, but also gives us indication of perfusion. The other important point of NIRS is that you can integrate it with other clinical hemodynamic assessment devices. So you can, for example, integrate it with POCUS, or point of care ultrasound of the bowel, of the heart, of the lung, or the brain. You can incorporate it with the Pulseoximetry, and finding the difference between Pulseoximetry and the local tissue oxygen, you can find the tissue consumption. You can combine it with invasive and non-invasive blood. If you can mute yourself. So you can combine it with invasive and non-invasive blood monitoring, and you can incorporate it with other clinical findings such as lactate level, blood gas, renal, and bowel assessment. Again, it's a real time. You can review it later, and you can use it for smart monitoring, such as frequency table, looking for the centralizing values, or variance of difference, or the extension toward the periphery, or also you can use the interquartile percentages, and you can do it as a histogram. Local tissue oxygenation is vital. Guess what? We do resuscitation, we monitor every organ, but we don't monitor the target organ, the organ that we want to preserve, which is the brain. So monitoring the measurement of the flow or of the brain and tissue oxygenation of the brain are vital, but we don't do it. We have only the invasive way, and it needs like very sophisticated centers. So what is the difference between the pulse oximetry and NIRS? Now, pulse oximetry, you have the transmitter and you have the receiver, and the organ that you measure is in the middle. So it's a straight. So it needs the two electrodes to face each other. However, in NIRS, that's a different. So the emitting probe is not indirect or facing the receiving, and therefore it sends the tissue or the wave in arc-like, or what they call it banana arc. So it sends it deep to the tissue and it brings it back. Now the depth of this determine how good the machine is. So this depth, or the depth of arc, varies between different machines. And this one is adhesive. So you not need to tie it around the organ or the tissue like in the pulse oximetry. So it's adhesive, you just go and stick it. Sometimes the skin is greasy, so you need to clean by alcohol or something, or water, or distilled water, and then put it. There are many types of near-infrared spectroscopy. I'm not going to go through it. It depends on the company, it depends on the intention, it depends on the price, it depends on. So they use different technology, and these are the technology that they use in near-infrared. So I'm not going to, because of the sake of time, not going to through it. Again, there are many companies in the market. All of us has a cons and pros, but the question is how many channels they give you. Second is what is the depth of the arc. Third, what is the mounting technology. Fourth is what the size of what's the size of the machine. What is the cost of the probe, and what is the service that this company can give you. And can you extract the data? Can you play with the data? And how they present the data, is in real time, or you give you other options. So again, these are the available devices, and you can choose which devices you like. And this is give you a list about what different devices measure what is the wavelength that they use, what is the variable they measure, and what is the result they give you. So again, you can review this on YouTube, pause, and then you can look and read it. So I'm not going to go through it for sake of time. Again, so how you find your device? Look at the number of the channels, ability to manage and manipulate the data, mounting technology, the size of the machine, the support they provide you, the size of the monitor, the depth of the arc, and the price and availability of sensors. Now, there is normal values of, in general, we've said it's 55 to 85, but there are normal values of the regional oxygen saturation and the fraction of oxygen saturation. And this is, you can see it's at the median and 25 and 27 interquartile here. Again, you can pause it, you can see the normal values. I'm not gonna look at it, but in general, it's somewhere between 55 to 85 for the regional oxygen saturation, and for the extraction, it's somewhere between 17 to 40%. This is again some values depending on the postnatal age hours. it can give you the range of the values of different parameters. Now, the beauty of the machine is the real time, because you can see it. It's better than the numbers. And some of the machine will give you a threshold value, and this threshold you can change it. There is a default threshold value, but the machine also can change the threshold values. And it gives you the two readings here. You can see the black one is the cerebral baseline, and you can see the light color one is the somatic. And you can see, usually you can see the variability of the light one, which is the somatic, is very high, while the saturation, the variability of the cerebrum is not very changing. And because the brain extraction ability is very high, then you see, because we've said the NIRS measure the venous, then you will see that the cerebral always below the somatic, because this, as we talked before, or at the beginning of the session, we've said that the cerebral extraction is way higher than the somatic, and therefore the venous saturation measured by NIRS will be lower, and the brain always stable. However, the somatic always variables, and the somatic start to suffer before the brain. Sometimes 1 to 12 hours before the brain starts to suffer, because there is autoregulation. So body start to deprive the organs, the vital organs such as the kidney, the bowels, the heart, from the tissue oxygenation to conserve and to keep some reserve for the brain. And you can see when the baby starts to suffer, the first thing will suffer is the somatic, and you can see the critical values here. So you can see when the values is less than 45%, it's a serious issues. But when the values are less than 50 and 20% below the threshold, it's warning sign. How you present in a smart way other than the real time? You can present it as a histogram, you can present it as a tachogram, you can present it as point care, and you can present it as a frequency table. Today, I'm going to present you only the histogram and frequency table for sake of time. So if we take the value of regional oxygenation and divide it into periods, the first period when it's below 45, and the last period when it's above 80, and the rest of the period, we go by 5 each, we will see that most people somewhere between 60 to 70, and they become less when they go to the hyperoxygenation and less when they become to more deoxygenation. And when the baby is hyperoxygenated, or the patient is hyperoxygenated, it's become negatively skewed or skewed to the right, or you're hyperoxygenated. So if you do that in last 24 hours, even your pulse oximetry is okay. You know that you're giving more oxygen to that baby during that period. Also, it can be positively skewed or skewed to the left, and which means that in last 24 hours or whatever the period you select, that the baby is under oxygenated, despite whatever the pulse oximetry is telling you. You can see it everywhere, haphazard, and this one usually, you see it usually when there is pain, poor pain and sedation control, but also you see it when some babies with pulmonary hypertension. The frequency tables give you the centralization values, the mean, the median, the mode in the last 24 hours, but also give you the variance, the increase, the stretching out values, which is the variance, the standard deviation, the range, the interquartile. And so when this increase, that means there is autoregulation. When increase to this side, then it's autoregulation. When it becomes more centralized, then you are losing the autoregulation. When you are skewed to one side, then you are either hyperoxygenated or underoxygenated. And these are examples, so I'm not going to through it quickly, but these are the centralizing value. These are skewed to the right, this is skewed to the left, and you can see it depend on the mode. When the median and the mean below the mode, then you're skewed to the left, and when the median and mode above the median and the mean above the mode, you are skewed to the right, and when all the values are the same, you are normal distribution curve. Sometimes you are normal distribution curve, but you are stretched out, like here, and sometimes you are normal distribution curve, but you are centralized. The more centralized, that means you're losing the autoregulation. The more variance you are losing the autoregulation, but also look to your sedation and pain control. So here it tells you some findings when it's centralized and it's somatic, usually absent, because we said there is autoregulation and the variability is high, while centralizing value normally present in the cerebrum. The variability usually present in the somatic, but absent in the cerebrum. Scud left and scud right should be absent in both. When the somatic more than the cerebral, which is normally, as we've said, because the cerebrum have more extraction, usually present normally and usually present normally. When the cerebral become more than somatic, it should be absent normally and absent normally. When somatic for the cerebrum, but with abnormal range, it should be abnormal, absent in both. So this is another, sorry, I'm moving fast. This is another change. So if we have centralizing value, if it's in the somatic, then it's loss of autoregulation. If you look at the variability, and if you see it in somatic, it's normal. If you see variability more in the cerebrum, then it's either pain or poor sedation. If it's good to the left, then it's hyperoxygenation in both. If it's good to the right, then it's hypoxia on both, or hypoxemia. If the somatic more than cerebrum with normal range, it's normal. If the cerebrum more than somatic with, I think this is abnormal range, that's mean this is abnormal range. This is typing error. So that's mean when it's become outside the range, that's mean the autoregulation, there is kind of compromise, but the autoregulation is trying to help. And the brain are decreasing the extraction. The brain start to suffer. However, the autoregulation start to help. When the somatic more than cerebrum with abnormal range, that's mean the autoregulation become ineffective. And there is impaired extraction ability of the brain. And guess what? This happened 1 to 6 hours before you see the first sign of shock. So cerebral, you see there is high flow and there is high extraction. While in somatic, there is variable flow and low extraction. It usually have lower regional oxygenation because the extraction is high, because the regional oxygenation is a venous after the extraction. While in somatic, it's higher because there is less extraction. There is compensatory mechanism that help, which is increasing the flow and autoregulation. While in the somatic, the autoregulation actually compromise the somatic, only help the cerebrum. So the only effect to keep these organs working is the flow, and usually controlled by sympathetic tone. The extraction, which is the difference between systemic saturation minus the venous saturation divided by systemic saturation, represent the flow, and in somatic we don't calculate the tissue extraction percentage. When we have cerebrum start to desaturate, it's a very late sign of shock. While when somatics start to desaturate, it's an early sign of shock. If autoregulation is intact, usually you will not see the cerebrum compromise. And if the autoregulation is working, the first thing you'll start to see is loss of variability, and it's very early sign of shock. Now, this is a future projection. I'm gonna pass it because of the sake of time. So I'm gonna end here the first session, and I see if there is a question or you guys want me to continue.
I think continue, Dr.
Do you want me to continue the second session?
Yes.
Yes, please, Dr. Yahya. Please go ahead. Can I ask our attendants also, in case anyone have a question, can you please post it to the chat box? Thank you.
You can see that I'm moving a little bit fast for the sake of time. It's really need more time to explain. However, sorry. However, if you have a question, we always can answer. So now, how we can implement the near-infrared spectroscopy? Now we will talk, the objective is to talk about the indication, about target ranges, and the changes in somatic perfusion and clinical application and normal range. So what is the indication? Where and when we can use the NIRS? Well, whenever your need for oxygen more than 30%, NIRS application is indicated. When that happens, hypoxic brain injury, respiratory problem, heart problem, HIE, trauma, pulmonary hypertension. You also can use it in necrotizing enterocolitis. You can use it during surgery to observe the viability of the organ, especially the bowel. When we do resuscitation, we want to preserve the brain. So it's vital to monitor the brain during resuscitation. Or we can use it to decide about the weaning, because we know that pulse oximetry have many artifacts, and sometimes we cannot wean, despite if you measure the arterial oxygen pressure, you find it high, however, the baby is desaturating. So it can guide you in addition to the pulse oximetry for weaning. When we talked about normal ranges, but here we'll concentrate more. So the typical ranges of the brain is, because of the high flow and high oxygenation, it's usually low. So it's somewhere between 60 to 80. So it's warning when it's less than 50, or if it's less than 20% from the baseline. And when it is less than 45 or less than 25% of the baseline, it's very critical. However, in the somatic is a little bit different, because the variability of the flow and the inability or the weak ability to extract oxygen due to autoregulation. So usually it's a 5 to 20% above the cerebrum. So whatever this reading, so it's 5. So it ranges between somewhere between 65 to 100%. And the changes of this relation between the somatic and the cerebrum gives you something. The cerebral somatic variance may be indicative of significant changes in perfusion, because the variability loss is an early sign. The somatic disturbance is an early sign. The loss of autoregulation is early sign, while the cerebral effect is a little bit late sign. So what are the somatic changes to perfusion? Perfusion changes to somatic tissue. It happens in sepsis, in shock, in hypoxia, in temperature changes, in anemia, and in compartment syndrome. So where we apply it? We apply it in the cerebrum. Where we apply it? We can apply it on the kidney. Where we apply it? We can apply it on the bowel. So how we interpret and monitor the oxygenation using NIRS? Of course, the NIRS should be incorporated with other clinical and monitoring devices with blood investigations. However, it is vital, the reason because if you go to the timetables of the presentations of different markers, whether it's a physio markers or a biomarkers, it goes with time. So when the insult happens, the changes in the somatic is immediate, within seconds. And the changes in the brain within minutes. The changes in the pulse, which is the first clinical sign, it takes about 30 minutes to 1 hour. The change in color takes more than an hour, and then all goes. For example, the lactate, it takes more than 6 hours to see a changes because of something called lag time, which is the time for lactate need to be built in to see to be seen as a difference. If you can look at the blood pressure, it's very late sign, and metabolic acidosis is the late sign. oliguria is a very sign, and renal defect is very, very late until we reach where there is a cardiac arrest. And here's another example of the cardiac output. You can see there is arterial side, which is measured by pulse oximetry, and there is venous side, which is measured by the NIRS. In addition, there is a blood pressure and the systemic resistance, which gives you the cardiac output. So these are the measures that can give you a complete picture. If you only measure the blood pressure and systemic resistance and cardiac output, you're actually seeing 50% of the picture. But if you see the venous side, you can see the full picture. You can see the arterial side. You can see how the tissue are doing because you find the difference, and you can see the venous side. Now, if you look at the blood pressure and compare it with the arterial oxygenation, and you measure the blood pressure, and you can see with changes of the oxygenation, the blood pressure reading is everywhere. So you can have very high blood pressure, though very good blood pressure, though your oxygenation is not good. So a blood pressure measurement is not good. There is another important point in the blood pressure. Blood pressure is measured by oscillometry, not the Korsakoff sound. And remember, oscillometry below 40 is incorrect. So having numbers in an ICU say, oh, 25 is low or even 10 is low is incorrect. You only have to look to the pattern of the blood pressure. Even if there is numbers giving you in the articles or in the literature that is normal, because they don't mean nothing. Because remember, we are measuring it by oscillometry. We're finding the pulse transit time, which is the difference between the PPT or photoplethysmography in 2 points. And this have a margin of error. If you're using Korsakoff sound, then that's a different story. But if you're using oscillogram, then remember, below 40 is incorrect. So don't stick to the numbers if other finding is okay. Blood pressure is okay, but the heart rate is okay, oxygenation is okay, but the blood pressure is 15. It means nothing, actually. Here's the heart rate with the oxygenation. You see the heart rate is everywhere, despite the oxygenation is going down. And again, as we've said, the regional oxygen saturation measure the oxygenation in all the parameters in all tissues, but it's more venous weighted. So it represents 75% of the venous. Now, the trend are very important. So look here at the light color of the reading, and look at the dark of the somatic, and look at the dark color of the brain. You can see baby start suffering. There is deprivation of somatic tissues, and the somatic tissues are trying to help, but there is actually no oxygen going outside the brain because the brain is using everything because of the suffer. So you can see here this baby in shock, and they started dopamine. So there is a little bit of improvement of the oxygen saturation at the venous side, 77%. But there is another dip. And here they give some sedation and a little bit of improvement. Here they added some dopamine, and then there is improvement. Once the improvement, the somatic are improved and then start to have autoregulation, then the brain start to let it go, to leave some oxygen going to the venous side, and then you can start recording. So all this period, the brain was suffering, and here we are recording. And you can see the variability of the somatic, and it's above the cerebral. So the trend are very vital when you monitor. If you do post-processing, you can see here in histogram, it's a scoot. It's scoot toward hypoxia. While here you can see it's a normal distribution curve. You can see here also normal distribution curve for the somatic, but you can see it's more variability. So what is the clinical approach when there is the tissue oxygenation index or regional oxygenation are less than 55%? The first thing I do when I'm connecting my NIRS, I look to the iatrogenic causes. So if the baby ventilated, look at your mean airway pressure. You might be having high airway pressure compromising the venous return. If the PCO2 you have below 55 and the PCO2 below the normal range, or even within normal range, consider decreasing your minute ventilation. So if you are hyperventilated and washing CO2, and as you know, washing CO2 can decrease the flow to the brain, and therefore decrease the oxygen saturation, and therefore make the brain extract more, and therefore you will see less oxygenation on the venous side. So if your MAB is okay, look at your CO2. If you're ventilated and your CO2 is okay and your MAB is okay, then, and your blood gas is okay, then go and assess your cardiovascular system. Look at your blood pressure range, remember, range, at least 15 minutes, at least 10 readings. Do not assess or judge the blood pressure below 10 reading. You at least have 10 readings with 2 minutes or 3 minutes apart. So even if normal range, and there is a clinical range of cardiovascular compromise, look at the lactate, look at your capillary refill, and measure urine output. Because when the tissue oxygenation less than 55, there is something telling you there is something, but we don't know what is that thing. You need to look at it. We know that low blood pressure might be not accurate. And the mean blood pressure is nothing but calculation of a number from systole and diastole. It's a beautiful number to use, but it's a deceiving number. It's a number that make your life easy. So please don't look to the mean blood pressure. Look at the systole, look at the diastole. Look at the trend if they are going together, or if they don't like each other, they are separating. And if they are separating, is the systole going high or this diastole going high? Are they like each other, start to meet? And what is the pulse pressure, the difference between them? And based on that, and with your NIRS and echo assessment, decide and then you can do lung ultrasound. So if you are not hyperventilated, so you can do also lung ultrasound, and you look to your A lines. So if you have less A lines, but your heart is okay, that means you are losing you are losing the fluid, so you might need a normal saline bolus. Or your heart, if you have more B lines, that you have more edema, then your heart is not working, so you need a push. You may need a dobutamine, or maybe you need a dopamine. So you need to interpret the lung ultrasound finding, the A lines and B lines, with the status of the heart, the contractility and collapsibility of the inferior vena cava and the pulmonary veins, with your NIRS finding. And then you can decide there is not any more normal blood pressure and abnormal. There are not any more, you give normal bolus, then dopamine, then dobutamine. That's incorrect. You need to do a hemodynamic assessment. And the first trigger of this dynamic assessment is your NIRS. If no response to all these measures, look at your heart. Is your heart is hyperdynamic? And is your systemic vascular resistance and I showed you from NIRS how we can calculate it. You can go back and see how we calculate. Consider vasopressor. Poor systolic myocardial performance, then consider inotropes. If there is PDA, consider treatment. You need to exclude congenital heart disease, especially total anomalies. And you need to assess the arch of aorta. Assess your oxygen transport, because there's all the problem. You might have low hemoglobin. And remember, when we say low hemoglobin, it's low for that particular baby. So you might have hemoglobin of 12, and it's not good for that baby. You might need to transfuse, actually. So you need to calculate your oxygen transport and oxygen carrying capacity, and the equation I already provided. So consider blood transfusion, and please don't look only to the number of hemoglobin. Assess your respiratory status. What is your systemic oxygenation? You might need to increase your FI2, but please do not exceed 40% more than 15 minutes. If you're giving oxygenation more than 40% for more than 15 minutes, There is something wrong either with you or with the baby. You might need to optimize your functional residual capacity, or consider other causes of hypoxemia, such as pulmonary hypertension, or limited diffusion, or you have mismatch, or you have sedation problem. And sometimes you need to consider muscle paralysis. When the oxygenation is more than 85%, assess your respiratory status. Assess your systemic oxygenation by pulse oximetry. You might need to decrease your FiO2. You might need to decrease your mean airway pressure. If your CO2 is high or normal range, consider you increase your minute ventilation, because remember the tidal volume is not the issue, it's the minute ventilation is the issue. Consider please your glucose level, because low glucose affect the tissue perfusion or the flow to the brain. So please assess it, and if it's below 2.6 or whatever the target in your unit, you might need to increase glucose load. Even if it's 3 or 4, please consider oxygen load when the brain is suffering. So when infant is at risk of hypoxemia, that's when you're using more than 30% of FiO2 for more than 1 hour, do hemodynamic assessment. Assess the pulmonary circulation. If the pulmonary circulation is not affected, do oxygen tolerance with NIRS. And then guide yourself to wean the oxygen depending on the systemic and local tissue oxygenation using pulse oximetry and NIRS. If the pulmonary circulation is compromised, then you either have pulmonary hypertension and then you need a trial of nitric oxide, and then guide using both. If it's pulmonary over-circulated, then consider PDA, and then guide yourself to wean by pulse oximetry and NIRS. When the NIRS become more than 80, and still you need more oxygen, assess please your glucose and your CO2. And wean the oxygen to maintain the oxygen target. If your NIRS is below 50, still with all these actions, check your MAB and your PCO2. Correct the hypocapnia. Check your hemoglobin. You might need to give a transfusion. Sign of circulation, there is compromise, do targeted neonatal echo. Do cardiac respiratory POCUS. If it's hypovolemia, which means the heart is functioning well, the heart is pushing well, it's collapsible, but you have more A lines, which means you're losing the fluid from the lung. So probably you need volume expander. If your cardiac function is poor, you might need to consider inotropes or vasopressor, depend on the category of the shock, and continue monitoring with NIRS and saturation. So decreasing NIRS value, you might need to increase your FiO2, you need to improve your CO2, you might work on your blood pressure, you might need to work on the pump, you might need to decrease the oxygen consumption by brain, giving more sedation and if necessary paralysis. You might need to vasodilate and you might need to transfuse. These are examples of analysis of the result of different group of ICU, where here they use only 1 to 35 NIRS machine, and you can see extra machine, the outcome is good. So please mute yourself. So I'm going to pass this. And my last message in the second session is, please give time to the baby. Avoid boluses as makan. And when I say bolus, every bolus in ventilation, bolus in surfactant, bolus as a normal saline, bolus as a medication, bolus as a sugar, bolus as a noise, bolus as a light, bolus as a touching. Please be gentle, give slowly, consider all and give minute for your action. And thank you very much. So I'm done with the second section.
Thank you.
Sorry, I'm
Thank
moving
you very
very
much
fast for the sake of time.
No, I think It's completely fine. Actually, we enjoyed the presentation and the slides every time I listened to your lecture, Dr. Yahya. Thank you very much for the informative presentation. And I would like to leave the ground for my colleagues and
you guys now, sorry for interrupting. You can ask the question, and if there is no question, I can present cases.
yes, of course. We can allow a few seconds. If there is no question, you can start with the cases, of course. Yeah.
Yeah. So you can ask a question, or I will read the questions.
If you can see the chat box, Doctor, it's completely fine if you like to directly read the questions.
Okay. Well, Ali say what I can do. There is no sound.
Oh, this is a technical issue. Yeah.
No questions so far. Either I was very boring or I was very clear. So no question.
No, Dr. Yahya, I should comment really. It's really very excellent presentation, Dr. Yahya. I mean, the practical guidelines which you have mentioned, you know, though it is a complex one, you know, it means that any baby who is sick, you should have all the things available around the baby, and there should be expertised people who should do the ultrasound of the lungs and, you know, assist the baby in a way just to give any interventions. That's a very, very reasonable approach, but practicality in your unit or in any other unit, how much it is possible really? I mean, is it, you need to have all the expertise all around you. Is that right?
For the NIRS, you can use it alone. You can guide yourself without other devices because you can compare the result between the cerebral perfusion and cerebral oxygenation and extraction with the somatic. So it can guide you about the shock. You can still give medications and intervention blindly according to your best guess using your available resources. But if you have more tools, then your decision will be more evidence-based. But you know, if you're losing variability, you're having a problem. So let's assume that you are moving a baby from an ICU or from labor room to the NICU, and your saturation is perfect on the Pulseoximetry, but your NIRS is dropping. So remember, you are doing hand ventilation, for example. It's just you are doing it very fast, and you are washing CO2, and the CO2 interfere with the brain perfusion, and therefore, oh, I'm desaturating. That's, you know, I need to slow down. If your blood pressure is okay and your capillary refill is okay, then probably you're doing it. So what you do is think about your respiratory care, and if your respiratory care, the CO2, the MAP, the functional residual capacity or the minute ventilation looks okay within normal ranges, then think about your heart and look at whatever is available you, lactate, your somatic perfusion, your blood pressure, and then decide if there is a cardiac. And if you cannot decide, you probably need more expertise. So point of care ultrasound using for the heart and the brain and the bowels should be a standard of care. And I don't think only neonatologists should do them. I think medical students should do them. I think there is a point that we should leave the stethoscope. I think the era of no stethoscope is coming. I know some people will resist it, but the era of echoscope will be coming sooner or later. And some people are arguing that interpretation is difficult. And I can say the interpretation of X-ray or stethoscope finding, the wrong interpretation, it won't be a difference from ultrasound. If you wrongly interpret an ultrasound, you will wrongly interpret an X-ray. There's no difference. So still you can use the NIRS with your available resources. And I can tell you it makes difference. It really makes difference, especially with overventilation and over-oxygenation and ROP. And, you know, if you have a sick baby, start vomiting and you're not sure, this is overfeeding, this is possibly neck, you put your probe on the bowels, and if you see no variability, there is a serious problem. Now, if you have an ultrasound to check the bowels movement and peristalsis and perfusion, then it's all good. If you don't have, you may think of keeping the baby NPO and doing X-ray. So it really can help in certain scenarios without sophisticated bedside smart monitoring.
Yeah, I think that's a reasonable answer, probably. But are you recommending NIRS on the resuscitation room as well? I mean, the way we're talking now, probably. I mean, of course, this looks very decent, but how practical it is. But I don't see any recommendation anywhere. NRP has not even thought about it. Probably this would be a newer recommendation that we have to include NIRS in the level suite, or I mean, in the delivery suite, that at the time of resuscitation, during transport, and all this.
Dr. Khan, I think people are mixing between care of sick newborn or the golden hour or first hour of life and NRP. NRP is a program to organize and structure the resuscitations by both expert and non-expert. However, when you are expert, you have expert people arriving, they should also follow NRP for people not to confuse others, but also they should use their expertise. Now, there is in UAE a transport companies that can gather all the equipment, including high frequency on the resuscitator, on NIRS, and inhaled nitric oxide. It's all on a machine that is motorized. And guess what? You can move this incubator by your mobile. You can drive it by your mobile. It's here in UAE. You can ask for it. And if you want the people to make it to you, it's there. So can you use it in the resuscitations? I think yes. And if you ask my opinion, I strongly recommend. Can you use it on transport? I think yes. And I also strongly recommend. So it's your really decision. As you know, people on changes are different. There is the minor early, there is the major early, there is the minor late, and there is the major late, and there is the laggard. So I hope that all the audience are not the laggards, at least they are early major when they look to the changes and look at the evidence and recommend the changes to their, to the best of their babies.
Absolutely. Thank you so much. I think
Dr. Mustafa is asking a question.
Any other question?
Yeah, go ahead.
Anybody?
Dr. Mustafa is asking a question. In case of absence of echo or lung USS, is this will affect the NIRS interpretation?
No, no. The NIRS tells you the loss of variability of somatic. That's mean the vital organs start to lose the autoregulation to reserve the brain. And when the somatic becomes below the brain, you know that it's compromised. And when the brain starts to decrease, you know that it is compromised, but it cannot compensate. And when you don't see the reading of the cerebrum, then you know that the brain trying its best, because the support and the help from the colleagues, which is the vital organs, are not anymore. The colleagues of the brain, which is the heart, the bowel, using the autoregulation to help the brain. And if you're losing the autoregulation, you are losing the help. So what the colleagues, they become, they try to give the way to the brain and start to compromise. And that's all the compensation that they can provide. And this all happen before you see the signs. And then the brain would start to extract all the oxygen. So it leaves nothing in the venous. So you start not to see anything in NIRS. And when that happens, you see the somatic and you don't see the reading of the cerebrum. You are very serious. Now, what is the reason? It might be respiration. It might be cardiac. Or it might be the transporter, which is the hemoglobin. Now, you have to use all your resources that are available with you to decide which is which. Either are you hyperventilated or you're hypoventilated? Is your heart compromised or your heart not compromised? Is it a peripheral issues or it's a central issue? Do you need to give volume or you give inotropes or you need to give vasopressors? Do you need to give blood transfusion or you need to give sedation? Now, to know you need sedation or actually you need it's a cerebral or it is somatic issues, look at the frequency table. Do you have centralizing values, which mean laws of variability in the somatic and normal in the brain? Are you going to the periphery? Are you going to have more variance of difference? Wider standard deviation? That means you are getting wider variability. So if that's either normal or the baby is very unhappy, your sedation is not good. Or also in pulmonary hypertension, you can see the very wide variability. So if very wide variability and you have pre and post difference and not a good oxygenation of the brain, then probably you have pulmonary hypertension. Not bad to try inhaled nitric oxide if your baby is more than 35 weeks. If your baby less than 35 weeks, the evidence said you need an echo before you decide. So you can still interpret by the best. So the brain and somatic saturation just tells you that there is a problem. And is it the problem compensated or not? And the problem, when there is low oxygenation in the heart, in the breathing or in the respiratory system, or it is in the transporter. So you have to decide.
Okay, I think we should proceed to the next section of yours.
I'm going to prepare some cases to show you the.
Excuse me, Dr. Yahya. I have one more question. I'm sorry. There is any limitation for NIRS in case like congenital anomalies of the brain or gut or kidneys? It will give me wrong informations.
Okay, well, that is a great question, Dr. Is it Dr. Mustafa, right?
Yes.
Yes, yes.
The great questions. The answer to that, we don't know the normal values for abnormal organs. So if the brain are abnormal, we don't know the normal values. However, the trend is still there. So if your kidney is abnormal and your reading is low, you still have the variability. You still have the relation between somatic and cerebral. So it's good idea if your baby is stable, like for example, and is not in support, and he's feeding very well, and you put ultrasound or the probe of the NIRS on the kidney, and you see your normal values in your population and your babies, and you start to have an idea what are the normal values. But that's a very good question. We don't know what is the normal values for organs that are abnormal.
Thank you.
Okay, shall I start?
Yes, please.
Okay, so we can stop anytime because these are cases. So I'm going to go right away to the presentation. Okay, so you can see here the pink color is the brain and the green color is the somatic. You can see with me also that the somatic are very variable. And you can see the variability was very good here. And you can see that there was dipping below 40% at some point. But with the compensation and autoregulation, the rebound corrections. However, you can see with time, so start here at 0, 0, and you can see after probably 3 hours, the compensation become less and less. Until a point, you can see that the somatic cannot go back. And you can see that there is more variability of the brain. At some point, you can see that the baby gave up and the saturation of the brain going crazy down. When the resuscitations or the patient start on ECMO, you can see that somatic start to improve with variability, but first the somatic makes sure that the main target is the brain went back to normal, and then start to lose or prevent the autoregulation from compromising the somatic. So you can see that before cardiac arrest, by around 9 hours, the baby was suffering, but nobody could see that. Until the baby all of a sudden start to have cardiac arrest. So if we do block smart monitoring, you can see how skewed toward hypoxia is the histogram. And you can see here more skewness. You can see here is a little bit better toward the center, and here it's completely skewed. However, when you look at here after the correction, looks like centralized values. You look to the brain, despite it is skewed in the somatic, the brain is still within normal range because it's centralized. And you can see here the brain start to suffer because the hypoxia strike the brain. And you can see the brain went back to normal when they did the ECMO. So blocking smart monitoring can help you to decide. Now you can see when there is low cardiac output, because I want to cross or pass the presentation of the case for sake of time, but I'm going to show you the pictures. You can see here that the brain are suffering and the somatic are suffering more. So once a fluid was giving a little bit of improvement, and you can see when they start inotropes, the somatic improve a little bit. When they give sedation, more improvement. When they give blood transfusion, almost everything went back to normal. And you can see here that it's very clear how the finding and different intervention affect the somatic and cerebral local tissue oxygenation. And if you do smart monitoring, you see the skewness and the centralization after correction, and same with the brain. Now look at here. So I pass here. So look at the saturation of the brain. So these are the values in the OR. Look at the marker of cerebral perfusion. Look at the somatic perfusion, how it went down. Look at the cerebral perfusion deteriorating. When the patient arrived to PICU, connected to the ventilator, and right away the saturation improved. And therefore, what happened here, there was only because you can see that the somatic knows that there is nothing wrong with the circulation. There is nothing wrong with the perfusion. But what is wrong was with the flow because of hyperventilation. So the people that doing hand ventilation was doing it very fast and washing CO2. And therefore, when the baby arrived to an ICU or the PICU, the somatic perfusion was almost okay, but the cerebral perfusion was affected. Once they connect to the ventilator and the ventilator was appropriate setting and the CO2 start to build up, everything went back to normal. So this how vital is during transport monitoring of cerebral oxygenation and somatic. And again, if you do a histogram, you will see it like that. So at ICU was almost okay, but the cerebral oxygen was a little bit affected, probably because of the sedation and the surgery. But all of a sudden, during transport, there was a skewness of the cerebrum. However, the somatic was not affected. Once they connect to the ventilator, the cerebrum start to be normalized. So the autoregulation was okay. There was no shock. That's what tells you the variability is there, but the problem with the local tissue or the brain blood flow because of hyperventilation. Another presentation. So here you look to the cerebral oxygenation. was always preserved. And look at the mesenteric. Before decision to treat due to stenting or stealing and ischemia of the bowel. So if you give feeding to this baby, you're probably going to insult the bowel. But you can see that cerebral oxygenation was okay. So that means the flow to the brain was okay. And the brain does not need the help from the autoregulation and colleagues. However, the lower body was affected because of the PDA. Once the PDA was treated, the somatic resumed the autoregulation. Now, there is a story behind that because I don't want to tell a story because I don't want to spend time on it. And here, where is the PDA was treated? And you can see the difference. The somatic was good, but the cerebrum was normalized or normal distribution. And when they treated the PDA, the somatic was become centralized. Look at here. Look at this baby on day 2 of life. He was on CPAP, or he or she was on CPAP of +8 centimeter, and he needs 27% oxygen, and he was on 92. The pulse oximetry is a little bit skewed to the left with a negative skew due to hyperoxia. But the saturation was not great. So the people, what they did, they give more oxygen. And despite that, the saturation was 89. However, you can see here that the baby is hyperoxygenated. On day 9, because of that, they increased the CPAP pressure to 9 centimeter water and the FI2 to 33. Despite all of that, the saturation was 88. So the problem was with the measurement of CO2, of the pulse oximetry. It wasn't a baby problem because the brain saturation was always okay. Not only okay, but it was hyperoxygenated. So local tissue oxygenation can tell you because the artifacts are less than the artifact in the pulse oximetry. So you can use it in acute kidney injury. I'm going to pass this for sake of time. You can use it for feeding tolerance. So how you do that? You look at the brain saturation, looks okay, which means the saturation or the brain is extracting normally, leaving some oxygen to the venous. That's when the brain does not need colleague, and the brain does not need the backup plan, which is the autoregulation. However, when you go to the colleagues, there is no autoregulation, there is no backup plan. And therefore, the problem was after the flow went to the brain, which means you have a problem with the lower. And mostly it is either compromised bowels or PDA. So that can help you to decide whether your feeding intolerance is due to some compromise, and also can help you whether you should stop feeding or prolong MPO during transfusion. So it's very important to monitor the bowel by NIRS during, for example, if you have a very small baby and you have some feeding problem. So this is a very important picture. You can see here is the cerebrum is not compromised until here. So you can see that the tissue variability is low and there is wider area between the cerebrum and somatic tissue. So what the people did, they increased the MAP on the ventilation from 16 to 17 to improve the oxygenation. And here, they're still not happy, they give another dose of surfactant. There was improvement in the somatic, but it's dropped again. So what they did here, they started dopamine because they think it's a cardiac. There is an astute neonatology who is looking to the grafts and loops of the ventilator and this decided that's a ventilation problem. That's a minute ventilation problem. So he decreased the MAP and switched the baby from conventional to high frequency. And he doped MAP. He was able to drop the MAP to 15. And look, right away, the colleagues and autoregulation not anymore needed, and the somatic jumped over the cerebral oxygenation. And again, if you want to smart monitor it, it will be in this way. You see the skewness and almost normalized centralized value of the cerebrum. Now, also, if you look at here, the relation of oxygen saturation, it's very well related to the oxygen measured in the vein. So the more values, the more oxygen in the vein. So if you use invasive oxygen monitoring of the vein, it is very correlated, which means it's non-invasive, but it's almost as accurate as invasive measurement of the oxygen in the vein side. Now, if you look here as occlusion of the carotid artery, and you look at the cerebrum and the venous, you can see when there is occlusion, right away deceleration, remove the occlusions, improvement, occlusion again, deterioration, improvement. And you see how, despite the cerebral or the somatic is not affected. And this on the liver, on the bowels, and on the kidney. And you can see the difference when you occlude. It's right away, in minutes, it gives you the effect on the brain, which is mean that it measures the flow to the brain instantly, although it is non-invasive. Validation of measurement. We want to know whether this is a true measurement or not. We can occlude or release the renal artery, and you can see right away the changes in the kidney. In perioperative patient management, we can use it. So I'm going to pass this. And I'm going to end my cases. I have more cases, of course, but I will be happy to take more questions. So I am done. And I hope that I did not bore you, and I hope that you guys get some benefit from these. So if you have a question, I will answer the questions. And if you want to implement this in your department, I can come and give you hand-on. If you want a normal values, I can provide you. If you want a protocols or guidelines, I can provide it.
I think that's a great presentation, Dr. Yahya. I believe we definitely need, say, protocol guidelines and at least some kind of nomogram to follow if you are really using NIRS in any of the units. In my unit, I haven't yet used it, but definitely we have a great intention to start it. But all the time we were looking forward that how to interpret this, and exactly the way he was showing it. Probably, I think this is very, very useful. I believe all the audience over here must have been very impressed. And every scenario you have described is a real scenario in any NICUs. Hypoxia, hyperoxia, overventilation, and shock, sepsis. In everywhere, this can be used very judiciously, and every intervention what is being planned many times blindly, but at least there is a validation, there is a proof that you are going to use the real thing, and that's a real great presentation, Dr. I am really so impressed. I believe any question from our audience will be very most welcome. Anyone from the audience, if you want to ask any question, please, Dr. Yahya.
Dr. Yahya, you are on mute. If you like to share also your ideas. Actually, I don't have, I cannot see more questions on the chat box. Our audience are really happy, Dr. Yahya. Thank you very much again. Their positive feedback as usual, and requests to repeat the lecture. So I would like to thank you also.
And you distribute it to everybody.
Yeah, we need the possible, Dr. Yahya. Thank you very much for your informative lecture, actually. They need the PDF or guidelines that can help us. And thank you very much.
Absolutely. I can give you a PDF of the lecture and also a PDF of the guidelines.
Yes, doctor. Thank you.
And by the way, Dr. Mustafa, Dr. Yahya, actually, he made it live on the YouTube. So I believe that it will be there, Dr. Yahya, in case.
anybody can review it. Yeah, I sent the link so you can review it anytime. Presentation. You can repeat the presentation. You can actually pause and take whatever you like. But also, I'm happy to provide the PDF.
Very good. I already subscribed, so thank you very much for the live webinar. And a special thank you to Dr. Anwar Khan, who actually presented the idea and he wanted to make it happen. And Dr. Mustafa, of course, for the arrangement. Thank you very much. And wish to see you all soon.
Thank you very much.
Thank you.
Mr. Mohammed, also that we appreciate that you took this step to organize this webinar in the Zoom, and that's really appreciated. Thank you very much, and thank you everyone who attended this meeting today. I'm sure they have got a benefit, though you need to practice it. Without practice, people tend to forget.
Yes, I agree.
Okay.
Definitely.
Thank you very much.
Thank you very much.
Appreciate. Thank you, Dr. Anwar. Thank you, Dr. Yahya. Bye-bye.
Thank you. Have a good day.
You too.